How's that?
Good.
Very good. Thank you very much for the distinct honor and pleasure of being with you all. I'm sorry I can't be there in person, but it is an honor to be able to participate in this. Just such a tremendous resource. Thank you, Dr. Parker, and all the everybody else who's been helping out. I am board certified in cardiothoracic. I do kind of specialize in chest cancers, which we'll talk about. I grew up in Atlanta. Grew up in Sandy Springs from about 77 on until about 2007 when I left. The last thing I want to say is my father in June passed away from dementia. He was probably the mixed type, so I have a lot of familiarity with it. So, but thank you very much for the opportunity to talk with you all. And we will get rolling. Today, my goal is to be able to say at the end that I've given some background, that I can familiarize you all with issues, and then also some of the terminology. I kind of liken this to, if my car is not working, I can Google all day long about how to take apart my engine, but there's no way I'm going to do it, and there's no way I know how appropriate things are. So yeah, I need somebody to tell me when things are appropriate. Educate, and then the most important thing, and that seems to be the theme of this program, this tremendous program, is to empower folks. Not only take care of yourself, but also to effectively engage with your doc. Because once there is a thought of cancer, it is turn your life upside down, scary thing. And you need to be informed and need to be able to step up and be able to ask and engage. So the other thing I like to say to my patients is, I'm going to tell you exactly what's going on in my mind, so that when we're done, you're kind of thinking, the same things I am. Obviously, you don't have the same background, but either way, I'm going to tell you what's on my mind about these things. So are these slides advancing okay? Maybe someone give it a thumbs up.
Yeah, we can hear you.
Perfect. Okay, thank you. I'd hate to just keep going on. Nobody can hear me. All right, so thoracic cancer, what does that mean? Well, the thorax is the chest. And so if you take away the bones and the muscles and everything, this is what you're left with. There's a ton of stuff in there. We're not going to talk about everything, but we're going to focus on the main ones. But you can see that there's lungs, there's heart, there's major vessels. Then if you take it apart even further, that you can see that there's esophagus. So what kind of cancers can you get in your chest? You can get lung, in the terms that you would need to know. There's non-small cell, there's small cell. Most of it's non-small cell. It's 85% of it. There's squamous cell type and adenocarcinoma, both of which are in the non-small category. There's esophageal cancer. We'll talk some about it. And the main types are squamous cell carcinoma and adenocarcinoma. There's things like mesothelioma, which is a cancer of the chest wall lining, which you may hear about in commercials, and that's related to asbestos. There's things like thymoma or thymic carcinoma. And so there's a host of things to talk about. We're going to restrict ourselves to lung and esophageal just based on time constraints. I wanted to just briefly run through some cancer terms that, if anybody has had cancer or gets cancer, you may start hearing about these, and it's good to know what they mean. So localized just means that it's a lower stage, it's smaller, it's usually curable. Resection obviously just means taking it out with surgery, and usually, especially in lung cancer and esophageal, if you're doing surgery for resection, that means that you're hoping to cure it. Adjuvant means that there's a treatment such as chemo or radiation that's given after surgery as sort of a cleanup job. Neoadjuvant is given before surgery, and that's usually to shrink it down to make it more amenable to resecting. Metastasis, bad word, we know. Spread, metastatic is a root from that root. Good thing nowadays, and we can talk more about it if there's any questions, but metastasis used to mean a death sentence. Nowadays it means tougher to cure, but maybe we turn it into a chronic disease like diabetes. And then palliation means that we treat it, but we're not curing you, we're just treating the patient give them some comfort. So, all right, let's talk about lung cancer. everybody asks about symptoms. If you have symptoms, you may have cough, with or without blood, chest wall pain, weight loss. Bad news is if you have symptoms, things are probably advanced. And so that's why we're going to talk about screening in a minute. And there's a lot of types of cancers that get screened, such as prostate, breast, colon, and this is one of them. Risk factors. This was a pre-submitted question, and we can talk more about it. Number one, the top 5 reasons, the top 5 risk factors are tobacco use. That increases your risk by 15 to 30 times. 90% of lung cancers occur in smokers. I can also inject another little anecdote about my family. My mother, who at 80 years of age got a lung cancer, she never smoked. So that can happen in non-smokers, and she got resected, and she's doing okay, thank God. Secondhand smoke, very common question. Not a lot of strong evidence for it. Avoid it. It's not good for a lot of things, such as asthma and those kind of things. The problem is, we will not buy you a screen. And we'll talk more about screening, but that being said, secondhand smoke is a factor, but it's not very well evidenced. 2 more risk factors: air pollution. In this study, this was a European study, and I think there's a lot more pollution in Europe, to be honest with you. There is a risk factor. There is about 50% more higher risk of lung cancer just based on particulate matter, particulate matter itself. And I just talked with a patient about this yesterday, radon in the soil, and there's a lot more in the south. So these are known risk factors, so they are proven. A question was pre-submitted, and I get it all the time about vaping. The jury is still out. Let me say this. So vaping, I always say to patients that vaping is not a good thing to start out with, especially with kids. I think it's a gateway substance use. But if the choice is between a hot death stick, like a cigarette, or vaping, then vaping's always going to win out. Nicotine, so when you vape, usually, aside from other boutique substances, usually it'll be nicotine. Well, nicotine is actually a natural compound made by the body, so it's not necessarily bad. The culprit is the hot smoke. So if nothing, a couple of points, if you leave here with nothing else, your lungs were not made to accept hot smoke. That's the problem. That's why marijuana is not good either. Now, the research will catch up with it, but inhaling marijuana is going to be just as bad because it's hot smoke with a bunch of carcinogens that are released from the flame. Demographics. Well, let's put it in perspective. What's killing us in general? And you can see that. So lung cancer is number 6. Ischemic heart disease. Oddly enough, this looked like it was before COVID, so I think everything moved down probably a slot during COVID. But so this is from what, 18? Yeah. You can see that Alzheimer's is actually just above lung cancer, interestingly enough. But so lung cancer is the number 6 killer in this country, actually, and worldwide. This is World Health. So it's still very, very prominent. It is the 3rd and sometimes 2nd leading new cancer, more than breast and prostate sometimes. From this, and I think this was 2020 or 21, it was the number 3 new cancer. It's the number 1 cancer killer, though. So of all the cancer deaths, lung cancer is far and away the top. It's still very prevalent. Just briefly, I don't know if you can see my mouse, but the red is the highest incidence in this country, and that's what they call the tobacco belt. Georgia's actually just not quite in the highest group. Interestingly enough, you can see that the Metro Atlanta area is kind of protected. That's pretty interesting. It's some of the more rural areas that have the higher incidence. This is a good breakdown by gender and racial classes. You can see that males, this is a theme, males across the board get more of these. And then you can see there is a breakdown: Hispanic, non-Hispanic, Black, non-Hispanic, white. So non-Hispanic, Black males, higher, probably the highest group of incidence of 66.5 per 100,000. You see non-Hispanic whites is just below that at 60. Same thing with deaths. This is the death rate of lung cancer per 100,000. So again, lower actually in Hispanics, but highest in non-Hispanic Black males and in non-Hispanic white males. This is a busy slide. What I want you to focus on, because this helps to kind of tickle our curiosity. What's going on with non-smokers? So what I want you to pay attention to is this upper graph, this blue line. The incidence of the percentage among smokers of non-smokers is going way up. Why is this? Hard to say. Maybe we weren't discovering them before, but there is, and the research has not caught up with us, I can tell you that. So there are more non-smokers getting cancer, lung cancer. Nobody knows why. Okay, so how are they going to diagnose you? And again, we'll get into more of this, but in general, how are you going to get diagnosed? Usually with a CAT scan, a lot of times with a PET scan, MRI not so much, but this is the majority of the time, especially if you have a resectable cancer, a low stage, localized, like I said, you're going to get your CAT scan this is a CAT scan of your chest, and right there with that red circle, that's what a lung cancer looks like. It looks like a cloud, but if you're going to have a lung cancer, that's a good one to have because that can be taken out and cured. You may get a fancy biopsy from and here's another one, another cancer there. If you can see that blob, hopefully you can see my mouse. But this is a fancy $1 million machine that is very good at sticking a needle down your throat into the mass, and you can go home the same day. So it's very, very advanced technology nowadays using needles to actually get a tissue diagnosis. And this is something that it's important that patients understand. CAT scans and other images are very good, but they cannot diagnose this. You cannot diagnose it until you have a piece of tissue on a slide that a pathologist looks at. So we get our biopsy, then we'll stage you, just like with any other cancer, with a prostate or breast. We will use official staging systems, such as the National Comprehensive Cancer Network. We will take, and I know this is real busy, but I just wanted to show you what we usually do. We'll take the T characteristics, T for tumor, the size, where it is, and then we'll look at lymph nodes, N for nodes, M for metastasis. And then when we're all done, this is the stage that you get. Hopefully you be stage A1 1A1. You may be stage 4A. You may be stage 4B. So this is how we stage it. We take the tumor characteristics, the lymph node characteristics, and whether there's a metastasis. And we come up with a stage. Well, what does that do for you? Well, I'll show you a couple slides to help clarify that. This pie graph shows that the breakdown of all the cancers that come in. Now let's pay attention to this dark green. That's localized. So a fifth of all lung cancers are localized, meaning that they may be curable. That's kind of low. That's bad. And I'll show you why. Look at this lightish green, the second to lightest green, 53%. Those are metastasized. So over half of lung cancers are found in a metastatic state. That goes back to what I was telling you, which is if you wait or I should say, if it's picked up after you have symptoms, you're in trouble. So that's the state of the art right now, is that over half are picked up in a metastatic state. That's not good. And we'll show you what's been done on that. Well, what does that mean? Well, remember the localized ones, 20% of them, they're in this dark green category that has a 63% chance of being alive in 5 years, even with treatment. So it's actually a little better than that in some select cases. But the point is that even sometimes you may only be 2/3 chance of being alive in 5 years, even if you had your cancer taken out. So lung cancer is a bear. It's bad. Look at these stage 4 people. I'm sorry, stage 4 people, 8% chance of being alive in 5 years if they find you metastatic. So hopefully what you're starting to realize is that if you got to find it early, and if you understand that, then that's what people have been doing for 20 years now. All right, so treatments. We'll brush past this a little bit. It's obviously a big topic, but you may have some combination of surgery, chemotherapy, radiation. They all, sometimes just one, it just depends. I have a couple of gee whiz slides here just to show you that when we do surgery, we've actually made a lot of um, advances. It used to be take out a whole lung or take out a whole lobe. Now we've identified that these little blocks here, looks like kid blocks. These are the segments of the lung, and we've discovered from studies that we can actually just take out an anatomic segment and leave the patient with a lot of lung left over, which is great because then you can go about your life and breathe and still have the same chance of cure. And so that's kind of the gee whiz on the surgery. That's the latest and greatest. The chemotherapy, just for familiarity, there's still a role for chemo, and that's the toxic stuff. Makes you lose your hair and you get nauseated, and platinum, taxanes, folate, folic acid blockers. But the hope now is mutational targets. So I told a patient recently that during the Clinton administration, when they did the Human Genome Project, we discovered that we could very expediently look at DNA and look at genes and mutations. And so that's what made this possible. We look for all of these mutations, and they got really technical names. But, when the patient goes to the doc may say, listen, you have an EGFR mutation, and guess what? I have these 3 drugs that will kill it very efficiently. So I bring this up so that you know some of the industry terms. I bring this up because in the past 15 years, the biggest breakthrough has been what's called immune therapy. And so you've probably seen commercials with Opdivo and Keytruda. That's what these are. And they've been effective in lots of types of cancers, including lung. And so very, very powerful. This is the coolest, and this ties in with the research because this is still not open label yet, but there's, this is what I would encourage patients to join in, is a vaccine trial. So they've taken the technology used for the HIV and COVID vaccines and the mRNA, and you take the patient's tumor, crush it up, and make a vaccine out of it, and then your immune system can kill it. I think it's so exciting. So that's on the chemo front. And then the gee whiz thing for radiation is something called stereotactic body radiation therapy, or sometimes it's called cyberknife when it's in the brain. And that's a zap that can be done for patients who don't have surgery. So those are the gee whiz things that can be done, for treatments. And these are pictures of the top left. These are CAT scans. The top left one shows the cancer at 6 weeks, at a year, and 18 months after they've been zapped with the SBRT. So, all right. This is the game changer. And if nothing else, hopefully you come away with this. Screening is the way to pick them up in low stage and cure people. And this has been an effort for the last 30 to 40 years among scientists here and abroad. I just went to a European meeting and it's the same thing. There's some interest in it. Patients who are 50 to 80 years of age, and if they smoked a pack a day for 20 years or 2 packs a day for 10 years, some combination. And even if you quit 30 years ago, you are still eligible. So you get an insurance or Medicare or Medicaid covered CAT scan every year. And you may have a copay, but they're covered. It's a low dose chest CT. It takes about 3 minutes. It's not a lot of radiation, and it's life-saving. Why we do these is because they found it saves lives. So this was the seminal study in 2011 in the New England Journal. They found among 53,000 patients that they dropped mortality by 20%. So just screening people, and right now to qualify, you have to smoke 20 pack years and be 50 to 80 years of age. So if you're in the audience and you fit that and you haven't been screened, talk to your doctor. We'll keep moving on. The screening does go hand in hand with smoking cessation. Here's the other thing I want you to walk away with. Among those people who are 20 pack years, 50 to 80 years of age, only 4.5% of eligible patients in 2023 use this. So that it's way underutilized. So there's a lot of lives being not saved because these scans are not being done. We'll come to that in case there's a question about screening. Let's move to esophageal cancer because there's a lot of questions on that. So remember, I showed you that this is SEER data. So this is National Institute of Health data. Remember I showed you that lung cancer was number 3. Well, esophageal cancer is number 17, so it's not nearly as prevalent. And it's not, it has risen 7-fold in the past 40 years, so something's going on. Here's the breakdown. So actually, we saw that, similar demographics, but non-Hispanic blacks actually have a lower rate than non-Hispanic whites, especially even in the males, interestingly enough. So, and it's the same thing with the mortality rates. You can see a lot higher mortality in the non-Hispanic white males versus non-Hispanic blacks, et cetera. And again, males get hammered over this versus females. There's 22,000. I think we already showed this. Okay. All right. So symptoms: difficulty swallowing, central chest pain, weight loss. Those are very vague, nondescript symptoms. So I think what it shows is that if you're having this and it's not going away, everything you've tried at home, then you talk with your doctor, because you may be missing something. They're very vague, and gosh, it's just the other night I was having, upset stomach. But if it's persistent, then you need to have it looked at. So as with lung cancer, the symptoms usually mark it, that it's advanced. There are risk factors: smoking, alcohol, chronic reflux disease, and there's a lot of questions on that. We can talk more about it. All right, and then there were questions on getting scoped. All right, so we talked about CAT scans to screen for lung cancer. Is there a screening for esophageal cancer? Not in the US. And the reason is because epidemiologists have deemed that it's not prevalent enough. Now, you make your value judgment on that. It's using public resources. Now, in Asia, where the incidence of gastric cancer is much higher, people do get screened. People get an EGD at, I can't remember which age. So we don't screen for these things. So that means that you have to have symptoms and go to your doctor. Now, if you have symptoms of trouble swallowing, chronic bellyache, vomiting, or even reflux, then when you go to your doctor, then they may say, listen, you may need a scope down your throat. So you got to be vigilant. So screening, not in the United States. All right, so reflux. I talked about how smoking and alcohol and some of these things are risk factors. Nowadays, reflux is the big risk factor. What does that mean? Well, it's just acid backwash. And I just had some the other night, and I took some Zantac, and I felt better. But this is something that, over time needs to be addressed with your doctor. So fatty meals, nicotine, alcohol, caffeine, heavy eating before bedtime can give you reflux. And actually weight gain fits in there too. So untreated, it can become pre-malignant lesions. And some of the names are Barrett's, or Barrett's esophagus, Barrett's disease. These are pre-malignant changes. So the normal tissue undergoes a 5 to 10 year transformation, stage by stage, meaning that it can be picked up early. Dysplasia. How are those managed? With a gastroenterologist, a GI doc. So you consult your physician. They will start with behavior and diet modifications and with treatments. So you guys are probably on some of these. The original developed back in the 80s was histamine 2 blockers, Zantac, Axid, Pepcid. The more up to date is proton pump inhibitors, Nexium, Prevacid, Prilosec. Those are good, but again, if there's still symptoms, don't stray from your doctor. All right, so if the GI doc does find that there's pre-malignant changes, they can burn it, and that's called ablation. And they need to be monitored still, because it can grow back. So you need periodic repeat surveillance endoscopy. All right, so just like with the lung cancer, remember how the 50 over here, I don't know if you can see my mouse, but at the 39% distant, that was 53% in lungs. So esophageal cancer, not as bad, but about 18% or 20%, just like with lung cancer, they're found in a good resectable state. So it's still pretty rough. At the bottom shows what happens. So remember that on the dark green at the far left, the localized, for lung cancer, it was what, 64%. Here it's only half of patients will live 5 years with no cancer. So that's pretty dismal. It's a rough cancer. The distance even worse, as you can see, 5.3%. So if you're metastatic, 5.3% chance you'll be alive in 5 years. So all underlines the fact that you need to be vigilant to try to pick it up. The treatments are we won't go into a lot of detail, but it's usually a combination, if it can be resected, chemo, radiation, and surgery. It's a big deal, but it is curable, and it's curable with a good lifestyle too. So what I'd like to do is wrap up. Hopefully there's time for questions. I've tried to incorporate all the questions that were sent to me, but I'm happy to field more. If you're a current or former smoker, get screened. So talk to your doc and say, hey, I've smoked. I used to smoke a pack a day for about 30 years and I quit 20 years ago. You can get a CAT scan every year. And we pick up cancers all the time, and they're cured. And if we had waited for them to get symptomatic, it'd be bad. If you have reflux, be vigilant with your doc. So you can certainly self-treat some, but don't sit on it because it can develop into other problems. And I think, like I said, just be brave and inform yourself, engage with your MD, your NP, and your PA. I do agree with what Dr. Parker was saying, that find somebody that you can talk to, who will engage with you, have a good discussion with, knowledgeable, but also will make sure that you're understanding. And if you don't like them, then always get a second opinion for someone, someone that you trust and who will steer you straight. So please take this down. These are my personal contacts. You can contact me anytime. I think in a crisis, when you got a new cancer diagnosis, the worst thing is that you don't know what's going on, and your doc is talking technical, and gosh, what does that mean, and what's next? So reach out anytime. So hopefully that left time for questions if anybody has any.
Hey, does anyone have any questions for Dr. Budde? Yes, I see one gentleman in a red sweater.
Thank you, Dr. Budde. I'm Kafri Kujichakalea Biff. I work with Thrive SS. My sister died of esophageal cancer, and she wasn't a smoker. She wasn't a drinker. And I'm now surprised to hear that there's no screening for it. But we grew up in Pittsburgh, Pennsylvania, and more specifically, we grew up in a neighborhood that was the highest elevation in the county of Allegheny. And at the bottom of that hill was one of the U.S. steel plants and a Westinghouse plant. And I'm wondering why has there been no study of how air pollution is affecting cancer in the United States?
Thanks for your question. There probably have been, I don't know of any, probably have been studies specifically with esophageal cancer, but as I showed you, there are definite data looking at pollution as it contributes to lung cancer, and there is a link. It's not nearly as multiplicative as smoking is. It was about 50% higher incidence. Some of these heavy metals and everything, I think that there is a definite possibility that there's links. I think research isn't there yet. And unfortunately, in some of the research game, I hate to call it a game, but you need to have enough numbers. You need to have somebody who's going to fund it. So it is a little unfortunate because there are there are people who suffer, but there has to be enough people for somebody to go, you know what, I think I see a pattern here. Maybe these heavy metals and this exhaust is contributing to these certain cancers. I have no doubt. And here's another thing that may help answer. So smoking contributes, of course, to the lung, but it contributes to pretty much every solid cancer you can name has a strong link from smoking. Well, I think there's probably the same thing from pollution, because I think that they're carcinogens that get released into the air and then they get ingested in your body, and then they find a way to cleave the DNA of some organ somewhere, and then it grows out of control. That's how cancer happens. Now, there's a contribution also from chance and from genetics. There's not a lot of genetic syndromes for esophageal or lung cancer. They are finding some genetic links in Asia for lung cancer, but not here yet. I think the research hasn't caught up with a lot of these things.
Well, we have a question up here, a 30-second question.
We got the question bouncer over here. Bounce me. I got to be careful. My name is Rick Turnbow. I I was wondering if there has been any correlation, and you mentioned it, but I'm curious as to whether marijuana use and cigarette use are there any comparisons that could be utilized for young people now who are using marijuana on a regular basis, and the effects that might be having on their lungs?
Yeah.
I know it's not cigarettes, but it has the hot smoke that you were
Yeah.
saying that affects the lungs. Is there any correlation or any caution that we could pass on to? I say pass on to the younger people.
Well, if you look at it from a strictly scientific standpoint, I don't know of any. I don't know of any data yet. It may still be need to catch up. I can say from a practical standpoint, from raising your kids, raising your community, guiding the youth, absolutely stay away from it. To be honest with you, and this is a little editorial, but and I've asked this before of people, and I drink alcohol occasionally, so I'm the first with the glass house. But why do we need to be intoxicated all the time? I mean, I know that there's stresses in life and everything. I think if that's the case, I think there's better things to de-stress with. I think in kind of black and whites, to be honest with you. So what you just said, which is what I said, which is the hot smoke. So you light anything, you ignite anything, you're going to chemically break it down into who knows what you're going to break it down into. And the cigarettes were breaking down into benzene and mercury and these other things. I mean, who would think that that's good to put that hot smoke with those carcinogens into your lung? Well, there's no doubt that the marijuana is the same thing. You ignite it, it breaks down into carcinogens that may or may not even have been identified. And then that doesn't even get into the psychiatric things we're hearing about chronic marijuana use. But I have two young daughters, and they're pretty young now, but I'm ruining the day that starts being something in their circles. But I'm gearing myself up for, you don't need to be intoxicated. You need to be. So it's a tough ethical question, but I can tell you, I am certain in the next 5 to 10 years that there's going to be solid data that the marijuana use is equally as bad as cigarette use. And so I think people are and I have a lot of patients who say, hey, I smoke it because it helps them relax, or I have cancer or whatever. And it's hard for me to be critical, but I never stray from the fact that the hot smoke in your lungs is not going to be good for you. It's going to ruin your lung. Your lungs are soft and fluffy and need gentle treatment. They don't need hot smoke in them. It will hurt you. You'll be on oxygen in 30 years. So I think some of these things are just common sense. That was a roundabout answer, but hopefully it helped guide you. I mean, we all made mistakes growing up. I mean, I never smoked, I never took drugs. Thank God. I don't even know how I got lucky not to get into a bad crowd. But we've all made mistakes and all done dumb things. But it doesn't change the fact that some of these things are just very harmful to us. And it helps us to, to do as I say, not as I do, where you tell your kids, just try to find something else. Try to get them to church. Anyway, I don't want to get on the soapbox on that.
Hello.
All right, we have 3 more
Yeah.
questions.
All day long.
4.
If you have the mic, it's your turn to talk.
Yes, you see this younger generation, every time they pick up a bag of chips or whatever, they can't eat it unless it's hot, hot, hot. So can you expound on that as far as being carcinogenic?
You mean spicy?
Yes.
That's a good question. The only link that I could definitively say is that the fatty and or spicy nature of it could easily, I mean, for sure, it's not speculative, definitely gives it a higher acid environment in your stomach. And then when you combine either some caffeine or some weight gain or whatever, then your stomach's ability, your esophagus's ability to keep that stuff down in the cauldron is impaired, and so the acid will be coming up. And chronically washing acid up your esophagus is a known contributor to esophageal cancer. So that may be why the rate's gone up by sevenfold in the past 40 years, is what you're talking about. So there's no doubt that diet contributes in that direct way by the acid. Who knows about the processed foods, how that impairs your ability to, for your immune system and those kind of things too. And then there's the weight. Weight loss is a known factor for having reflux because you have more backwash up your esophagus.
I wanted to ask the question. I have serious COPD. How often should they be giving me the CT scans?
Did you smoke?
Oh yeah,
You should get a CAT scan every year.
I'm getting them every 3 months now. How big of a centimeter of the lymph nodes indicates that you have a problem?
Lymph nodes are a different issue. They can be part of a cancer. They can also be their own abnormality. It's a bit of it's a slightly different discussion, but certainly need to be monitored by someone who's in the know and take into account everything. Can you have lung cancer, but it only presents with lymph nodes? Absolutely. So if you have big lymph nodes, you definitely need to have, if your primary doc doesn't feel completely comfortable handling that, make sure they get you to a pulmonologist or, even a thoracic surgeon to address them. Not everything needs to be biopsied, but it needs to be taken into account because you don't want to miss anything. But in terms of the scans,
to a thoracic surgeon.
say
And
again?
I went to a
Okay.
thoracic surgeon.
Okay.
They were thinking about some type of experimental surgery for me, but they told me in the end that I didn't qualify because I didn't have the, I guess, lung capacity. I wouldn't be a good candidate, is what they said.
Yeah. Okay.
Okay, now I'm looking at your information, and I was glad I came because these CT scans that I'm doing every 3 months, is that necessary?
Well,
Could I go to every 6 months?
Well, without knowing what exactly is going on, it's hard to say. If you're just a smoker and have no findings on your CAT scan, you need to get a yearly scan until you're 81. If you've got stuff they found, that's a little different story. And so it's hard to say without, like I said, you guys have my email. You feel free to, if you ever need any, guidance, happy to help you out. But you definitely need it once a year. If you screen and you find something, then the whole game's changed. Then you need whatever's appropriate. Let's say they find a 5-centimeter mass. Well, you're going to need surgery, more scans, these kind of things. So that it depends on if something's found on that screening.
Good afternoon, Dr. Budde.
Yes, sir.
I grew up in a region near the Mississippi River within 25-mile radius of a nuclear power generation plant, the only one in the state. Each time I hear of someone in the counties adjacent to the one I was born in on both sides of the river, they've died of some form of cancer. I know that there are a host of social determinants of health, diet, drinking, lifestyle, all of those things that contribute to cancers. But I'm curious as to whether there have been any studies that isolated the effects of exposure to nuclear regulation or nuclear waste or the fumes coming out of those power generation plants and cancer.
Well, I don't know about that. I know there's definite old data regarding, for example, Hiroshima and Nagasaki, where there was known radiation, and then of course the after effects for 50 years. And then things like Chernobyl, where there was a leak. In terms of contained or non-leaked areas, I'm not sure about that. But you do hear, interestingly enough, you hear about power lines and clusters of people with cancers. I can't say definitively can't steer you one way or another. And again, it may be what I've been calling the research gap, where research hadn't caught up with it. But I bet you there are some population studies looking at that. I haven't heard, it doesn't make our radar in terms of the top 10 risk factors. I think when it comes to these cancers, it pays to be to make sure you're accessing what is available, which is the screening, and then also if there's any symptoms whatsoever. And then that includes with your physician, I think routine blood work is very, very appropriate, especially once you get to the Medicare age, because, the Medicare, once a year, you do Medicare screens, and there's a lot of blood work that can be covered. The one thing that I didn't cover, I kind of glossed over, and this is a bit controversial, but there's a lot of people who now are self-screening. That's a very controversial in the medical field or in the medical community, because people are paying their own money to get full body scans or to get blood tests. And these are not, again, they're not approved. They're not approved as part of, public health policy. That being said, I've worked with a private, I shouldn't say with them, but I know somebody personally who has one of those private radiology groups. And anytime when someone screened themselves and they had a finding, they would send to me, and we found a lot of cancers. So there's a lot of people screening themselves. And I think that may end up, that's sort of in the research gap too. I think they're going to find that there's more people who need to be screened. The only reason I bring that up is I think that it's a moving target. Every time we think, oh, we've established this is gospel, this is what you need to do, things change. So there may be more people who end up getting screened. So I kind of strayed off a little bit on that. On the nuclear side, I don't know of anything for a safe area. I will say this as a bit of a side note. So in some areas, such as the Mississippi Valley, there are things that does make you prone to picking up fungus in the air that will go in your lungs that will mimic a cancer. That happens a lot. There's Missouri Valley, Mississippi Valley. There's things out Southwest where people can kind of inhale, fungus and those kind of substances that can mimic cancers. So be mindful of that too.
Dr. Butts, my question is two-part. When it comes to Barrett's esophagus, with proper treatment, is it possible to reverse Barrett's or at least slow the progression? And part two, at what point should ablation be considered?
Yeah, very good question. Barrett's can reverse. It can regress, yes. But it's, obviously it has to be under the really strict care of a gastroenterologist with good, solid monitoring, surveillance, and it's very well spelled out. I think it's the Montreal Protocol or the, so work very closely with your gastroenterologist in terms of your medicines, in terms of your diet. When it needs to be ablated, again, is sort of spelled out in guidelines, and I'm not an expert on those guidelines, but the gastroenterologist is going to be. They also need to surveil frequently, because little cancers can hide in among those. And if there's going to be a esophageal cancer that you get, you want to have one of those little ones that are a centimeter or less, because they can be scooped out without a big surgery and they can be cured. So hopefully that's partially answers your question. I didn't give you specifics, but you're in good hands if you're hand in hand with your gastroenterologist, because there's very, very well spelled out guidelines on how often to repeat endoscopies with Barrett's.
We're going to take two more questions. And any additional questions, please feel free to contact Dr. Budde.
Yeah, please email me or call me anytime or text or whatever.
Yeah, you had mentioned earlier about marijuana along with cigarette smoking. Can we also throw a couple other things in that boat? And I'm thinking about young people, and you have more young people looking at hookahs, looking at vaping, because they think it's cool. But I'm seeing like hookah spots popping up all over the place. I mean, even cigar spots, you get more women I see smoking these things than I've ever seen before.
Yeah. So cigar smoke, Actually, I've been known to smoke a cigar here and there too. Like I said, nobody's perfect, and I shouldn't. But cigar smoke is sort of in the category of secondhand because you don't necessarily inhale, but it's not good for you. And yeah, you know that. I remember we took our trip to Egypt like 15 years ago, and I tried a hookah out. It's kind of interesting. That being said, I think it falls in the category of adolescent behavior and bad habits. And so I think, like, hopefully this makes sort of answer. So like I said, when I have heavy smokers who come to my office and we talk about nicotine patch, gum, you know, medicines and everything. And then the topic of vaping comes up, and I say, well, if it's a matter of least worst, then the vaping is the least worst. You start on a higher dose of nicotine, come down, and then you're just doing water. If it keeps you from doing the death stick that you've done for 30 years, then it's a viable alternative. Kids is a completely different story because then it's a gateway. They're trying to get into it. If the kid's just doing vaporized flavors, it's not as carcinogenic, but the problem is it can cause bad infections, really bad infections, and it can cause fibrosis, which is maybe worse than cancer because it's incurable. So there's just no hiding. There's no free lunch, you know. I think it just falls in the category of kids experimenting and trying to steer them from it. But I know you want to arm yourself with like good science. I think the best thing you can tell them is that that can result in bad infections and also scarred up lungs. And I mean, you're 30, when you end up at 30 or 40 years of age and your lungs are already scarred and you're on oxygen, that's a ruined life. So,
Dr. Budd, before we move to the last question, while we're on the topic of tobacco, organic cigars are marketed as, and I've also heard of organic marijuana. Can you comment on whether there is less risk for cancer just because something is labeled organic?
are they smoked?
I believe they are smoked.
Yeah. Again, I'm a kind of a black and white thinker. It's funny that when you can read a lot about how there's been some sort of propaganda about menthol is not as bad or light's not as bad, but hot smoke, hot ignited, you know, carcinogenic byproducts, they're just not good for your lungs. Your lungs, think of your lungs as very fragile, spongy organs, and you only get two of them. And there's not really, you know, transplant's not a good option. There's not a lot to go around. Treat them good, you know, that you already got enough pollution in the city, or treat your lungs good. So I think, I don't know anything about organic. I would be shocked if anybody found any difference because again, it's just, you know, you're just inhaling. Like what if you lit a bonfire, went camping and lit a fire and then inhaled it? I mean, it's just kind of the same thing. I mean, it'd be nuts, cough your brains out. So I view it as the same way. It's hard though. I mean, I don't mean to come down harsh, and I don't come down harsh on my patients. You know, it's very addicting, but I try to be straight with them and say, you know, it's going to help you. There's a lot of really well documented benefits that happen within a week, 2 weeks, a month, 6 months, a year after you stop smoking. You can have some improvement in your lungs, your upper respiratory tract gets a lot better. Your sinus problems get better. And of course, then you stop damaging your blood vessels too. There's a whole separate side to it. Cardiovascular disease, needing a bypass, needing a stent, wrecking a valve in your heart. So lots of good benefits, but no shortage of things to scare off your kids and grandkids.
All right, Doc, we have one final question over here, but we have a couple of gentlemen asking for your contact information. If we'll get that back up on the screen while we ask this last question.
My question is related to scarring of the lungs related to some form of respiratory illness. How likely is that, or have there been studies that show or that it leads to or may cause cancer of the lung as a result of having some type of respiratory illness?
I don't think respiratory illness or scarring has a direct link to cancer. But to be honest with you, there are some scarring. Well, I guess you could kind of break them down. You could have COPD or emphysema. Emphysema is permanent damage. It will not reverse. And that will render people unable to move around, unable to breathe, tied to oxygen. Scarring is a bad thing too. And in fact, there are some scarring syndromes, interstitial lung disease, that are unrelated to smoking, and there's many that are related to smoking, and they are probably a fate worse than death. You definitely keep that in mind. You know, you got to keep that in mind when there's tobacco involved, is that it can cause scarring, and that's a miserable condition. But direct link between cancer and the inflammatory things, not really. One thing that can happen though, let's say you have a lot of scarring, or even this happened during COVID, cancers can hide in those pockets that you see on the CAT scan. That we saw a lot of that. Coincidence? I have no idea. It could have, I don't know. I haven't seen any studies to say there's a direct link, but you know, it does hide in there, and you don't want anything that's going to make your CAT scans more, you know, harder to read. You want perfectly clear CAT scans so you can get a clear diagnosis and, you know, no delays. So.
Thank you so much, Dr. Budde. Let's give Dr. Budde a round of applause.
I appreciate you guys having me. I think it's such a great group, and I'm sorry I can't be there.
So Dr. Budde, we usually forward our presenters slides. So if you don't mind, I'll send out a PDF copy for the gentleman after today's program. Will that be okay?
Absolutely.
Awesome, awesome. So you all see his contact information. I'll also include it in the email for you all. So thank you again, Dr. Budde. We appreciate you. Best wishes.
Thank you, guys.